afternoon, friends. After a long gap, we are meeting here. Today, we are conducting CME come live workshop with Dr. Surya Prakash Bhandari sir. We all are known and familiar with Dr. Bhandari sir and his work. Today's CME is unique because we are conducting live workshop with this CME. Now technology is advancing very fastly and our medical field is using this technology for medical education. So this is a good suggestion by Dr. Bhandari sir to conduct CME with live workshop, and we are happy to show you this CME and live workshop on before you. So now, not wasting much of time, I request our treasurer Dr. Anil to come here and introduce our speaker, Dr. Bhandari sir.
Hello. Once again, welcome you all on behalf of Bhandup Medicos, and thanks to our today's eminent speaker, Dr. Surya Prakash Bhandari sir. Sir doesn't need introduction. Sir is well-renowned interventional gastroenterologist attached to Gastrocare Mulund and Advanced Gastroenterology Center, Thana. Sir has passed his general surgery from Sion in 2002. Since 26 years, sir is practicing as a gastroenterologist, and sir is fellow in Indian Gastroenterology Society, across the world, Europe Gastroenterology Society, and American Society of Gastroenterologists. Sir is having much and expertise knowledge in ERCPs of complex CBD stones and GI cancers. Sir is treating with holmium laser and other GI cancers with ESDs like endoscopic submucosal dissections. Much we are learning from Dr. Bhandari, and thanks again for this live session, which is I think first time for our doctors. So once again, thanks to Dr. Bhandari sir, a well-renowned interventional gastroenterologist of Bhandup, Mulund and across Mumbai. Thank you and welcome Dr. Bhandari sir. And may I call Dr. C.V. Patil sir to give a flower bouquet to Dr. Bhandari sir for today's good session, for the start of good session. Thank you. Thank you, sir. Thank you, sir. Thank you. Let's start our live session.
Good afternoon all. Just before we start, let me just felicitate from our side the president of Bhandup Medicos. Please come. Dr. Pofre, Dr. C.V. Patil. As a special gesture, I also want to welcome Dr. Chandan, who is my mentor, and with his blessings we are going a long way now. Chandan sir, please come. Today, I'm going to show you some very simple endoscopy cases. Maybe some gastroscopy, colonoscopy, how some malignancies look like, how polyps are looking from inside. So you'll just get an insight. As everybody said here, technology is fast evolving, and rather than lectures, if you see a video, that will have an impact for years together. You'll never forget how a polyps looks like, what are varices, what is malignancy, how esophageal malignancy looks, how is an ulcer which is looking from inside. We all know our now kids are going into medical colleges. So if you also want to know what is happening latest in cardiology, what is happening in gastroenterology, then only you can choose a branch. So this is very important. So when you see a video, it will give a lasting impact. So let me show you very brief, because we are running short of time. So we will be starting right now and then we'll finish by sharp 4:30. Just give me that much time. And in the meantime, if anybody is interested, you can have tea and coffee also together. Thank you so much. So now I will be running a very brief AV presentation from our institute, and then immediately we'll start. So the meantime, I'll reach there. Thank you. And one last minute, I'll just request Dr. Chandan sir and Dr. Hemant Patil to coordinate as a moderator, so that if you have any difficulties, you have any questions, you can ask them or you can speak to us directly also. We have a two-way audio-visual system. Okay, thank you, sir.
Welcome,
Hemant,
welcome.
can you hear me?
Yeah, we can hear you very well,
So
clear.
now this patient is a first patient who has chronic dyspepsia.
Yes.
He has been treated multiple times with various PPIs and she
Okay.
still doesn't have relief. So
Okay.
now we have decided to subject her to a upper GI endoscopy.
Okay.
Now as you all know, patient is fasting for upper GI endoscopy for 6 to 8 hours. Now
Yes.
patient is in left lateral position. A very mild sedative is given to her so that she is very comfortable during the procedure. As you
Okay.
know, some patients are they have severe phobia about endoscopy. The minute you tell them endoscopy, they will get frightened and they will tell you that I don't want to get endoscopy. So what we do at our institute, we give them a very mild sedative, so that by the time endoscopy is over, they have no bad sensation or they have no bad memories about the procedure itself. So to make the patient comfortable, we have Dr. Smita Bhandari, who is anesthetist.
Okay.
We have our team here.
Endoscopy for a routine patient. When you can
Yes,
expect them
yes,
to
that
send
is
you
very
to you?
important, very
Before
important
any
question here.
medications, how many medications,
So
what are the
if
symptoms?
as per the guidelines are considered, if patient is having chronic dyspepsia and he doesn't have relief after minimum 6 weeks,
Okay.
or if there are very symptoms like weight loss
Yes.
or vomiting, then this patient should be subjected not but 6 weeks, when earlier also. These are called as red alarm signs.
Yes.
Red alarm signs. That means weight loss
Yeah.
or persistent vomiting
Yes.
or chronic diarrhea which is not responding. So all these things we have to do the endoscopy earlier, or maybe anemia. This is a very important symptom. Patient will not tell us that she has anemia, but we have to do a clinical examination and see if patient has significant anemia. That means hemoglobin is less than 8. So for routine patients, we generally give them PPIs for 6 weeks, and if there is no relief, then we do subject them to upper GI endoscopy.
Okay.
Okay? So now I'm
Yes.
going to start the process. The patient is comfortable in left lateral position. Are you getting the endoscopy image?
Yes, we can get the endoscopy. We are seeing
So
the
I'm going to
endoscopy.
start the endoscopy now here. As soon as I start the endoscopy, you can see a structure here which is called as vocal cords.
Yeah.
Here, these are the vocal cords, right and the left vocal cords. And many patients can sometimes have dysphagia, and we can have lesions here at the larynx also. So I'm now going to pass across the vocal cords, and as soon as you enter the vocal cords, we go across the vocal cords, we see the esophagus. So esophagus is around 40 centimeters in length. Now this is the esophagus. I am introducing the scope ahead. I am pushing some air so that I can inflate. These are all deflated structures like the stomach and the esophagus. We have to insert or inflate them with air like you inflate a car tube. So as soon as you inflate them, you can see nicely the esophagus, the esophageal lining, the GERD. If you want to see gastroesophageal reflux disease, now this is seen at the GE junction. So we have reached the structure here, the gastroesophageal GE junction here. You can see here, this is the GE junction. If there is patient is having reflux, we'll see here.
Yeah.
The mucosa gets inflamed. That also I am going to show you. Now this is a patient who is having only chronic dyspepsia. So now I am going to enter in the stomach. This is the stomach now. Again, stomach is a completely deflated structure, but if you get air inside, then it will get inflated. And I'm slowly going in the stomach and observing the gastric walls. This is the upper wall which you can see here at 12 o'clock. That is the anterior wall of the stomach, and exactly opposite is the posterior wall. And I'm pushing the scope right now, and I'm going ahead. And as you know, the end of the opening is the pylorus, and as you can see here, this patient is having multiple erosions.
Yes.
You can appreciate here,
Yeah.
multiple red spots here. So this is very important. This patient had chronic dyspepsia, and she also had chronic epigastric pain. And
Yes.
the pain continued. She was treated with various PPI drugs, but there was no relief. So what we have to do when we do endoscopy, we will also take a biopsy for H. pylori bacteria. And once you give them treatment for H. pylori, they will do excellent. So you can appreciate these multiple erosions here.
Yeah, yeah, very
Hemant,
well
can you
seen.
show to the our friends also, our colleague friends? These are all red dots here, 360 degrees you can see here. This is a erosions, multiple superficial erosions. They are not actually ulcers, but some of them are few early ulcers, but most of them are erosions. See, this is very excellent, you can appreciate here. So I'm going ahead, this is the pyloric opening, this is the black structure hole, this is the pyloric opening, and I am going ahead and we enter the first part of the duodenum.
Duodenum.
Okay, here also you are seeing red streaks, and there
Yeah.
is a ulcer here also.
Yes.
So this patient also has a duodenal ulcer. Okay, so in
Yeah.
gastroscopy we see till the second part of duodenum, and I'm going to enter the second part of duodenum here. This is the second part of duodenum. If you are lucky,
Looks
sometimes
normal.
you can see the ampullary opening also. You can see
Yeah.
the bile here.
Bile here.
Now this is fresh golden yellow bile is coming from the ampulla of the water, which
Yeah.
is present in the second part of the duodenum. You can appreciate?
Yes, very well.
Okay, so now I'm going to come back again. We have inspected the second part of duodenum. We have seen multiple erosions here. So this patient has lot of findings. That is the
Yes.
reason she was not doing well with routine medications. She was given lot of antacids
Yeah.
preparations. She was also giving proton pump inhibitors. But in spite of that, she was not having adequate relief. So this is called as the cardia and fundus of the stomach.
Yes.
Okay, so now what we are going to do is to take a biopsy for H.
Biopsy.
pylori. I will show you how the biopsy is taken for H. pylori.
Yeah.
Now this is a very small instrument, biopsy forceps. I will go inside and open and show you how biopsy is taken for H. pylori. Now I am going to push the biopsy forceps out of the scope. There is a channel. Open the biopsy forceps, please. Open. Now this is the biopsy forceps which is open, and close the biopsy forceps. Yes, so I will open the biopsy forceps, close the biopsy forceps, and you can see we have got tissue inside the biopsy forceps.
Yes.
Now we'll remove this tissue. Then we have this special kit which is called as rapid urease kit. Can
Yeah.
you appreciate here rapid urease kit? Dekho.
Yeah, that is what I was about to ask you. Most of you, the friends of mine, they send patients to you,
I
and
know,
they'll get
saturation.
a kit attached to their file. So what is that RUT, rapid urease test, and how
Yeah.
you interpret after 6
Hemant, can you
hours?
speak loudly because I am not able to hear.
Yeah, what is RUT?
Now it is
Rapid
called as
urease test,
yes, rapid
and that
urease.
slide you attach to your file,
Yes.
what
yes.
interpretation they should take away?
Yes, very important. Now show me that kit again. Show me that kit. Now what happens? This rapid urease kit has a urea broth. You can see here yellow thing.
Yes.
Yes, that is a urea broth, and this H. pylori will secrete a urease enzyme.
Yes.
So what happens if the urease enzyme is secreted by H. pylori? There will be color change from yellow to red. That
Yes.
means patient has infection. Suppose there is no H. pylori, there will be no urease enzyme, and there will be no color change. That means it will be yellow only. So this we see after 12 to 24 hours.
Yes.
If the infection is very high, then it will be turn redness immediately.
Yes.
And if the infection is not there, it will be yellow. So now we have done complete examination. Because of the shortage of time, I am going to go slightly fast. So in this patient, you have appreciated that there was multiple erosions in the antrum,
Yes.
and there was severe duodenitis with a superficial duodenal ulcer. So I am coming out. So when I come out, I will suck all the air from the stomach here.
Yes.
You can see here, I am sucking the air. I will decompress. Otherwise, what happens? There will be lot of post-procedure discomfort to the patient.
Yes.
So
it's
again,
very- yeah.
Again, when I am coming out, I am again inspecting the stomach or esophagus also, and now our examination is completely over. So as you have appreciated here, it will not take more than 5 minutes to do a routine upper GI endoscopy.
Slight lifestyle modification, upright posture, small frequent meals, no overeaters, Dr. Bhandari. Second thing is about RUT. You send the patient to the endoscopy, say, see the file, ulcer, say, I'll start medication. No, you have to call up that patient again on the next day after 12 hours or for 24 hours to see the RUT color. If the RUT color has been changed to yellow to pink or not changed, that you'll have to see. Then you'll get to know before biopsy. Biopsy report takes 4 to 5 days to get the H. pylori. Most of the times it is non-specific gastritis or duodenitis. So if at all RUT is positive, you'll have to start these patients with HP kit rather than only PPI.
Chalo, signal to.
Yeah, we are ready.
So I'm going to start the second case. Again, she is 55 years old female patient, and
Yes.
basically what she has is volume reflux. So we are going to find out. Again, she has chronic dyspepsia plus lot of regurgitation.
Yes.
Okay, so volume reflux is called as regurgitation. So we'll go in and find out. Again, she has been treated at multiple places. And as you rightly said, Hemant, most of our friends, colleagues, they also finish their clinic at 11 o'clock in the night.
Yes.
And then they have a heavy dinner. So what you want to advise them? So here, as you can see, this patient is having a big hiatus hernia. So
Yes.
I showed you last patient, see, this is a big hiatus hernia here,
Big
and that is the
hiatus.
reason this patient is having volume reflux. That means if you lie down immediately after meals, most of the contents from the stomach are going to regurgitate in the esophagus. This is what is called as volume reflux. Now this patient, so here we are going to see if patient has also what is called as Barrett's esophagus. That means because of the chronic reflux of the gastric contents into the esophagus, the lining of the esophagus will turn into Barrett's, which is called as early. It is a pre-malignant condition.
Yes.
So now this patient, he is having a hiatus hernia which is almost 3 to 4 centimeters in length. Okay. So, but we'll focus on this hiatus hernia when we come out. But we'll as we do in every procedure, we just go in and appreciate rest of the findings first.
Yes.
Now this patient also has been treated multiple times, but still you can see here there is lot of gastritis. See,
Yeah.
lot of red dots everywhere, pan gastritis. Multiple places there are red dots. So again, this patient will require treatment for H. pylori, and then we'll progress. So I'm going ahead again and see if there is more findings here. So one finding is a big hiatus hernia. Second finding is lot of gastritis, pan gastritis, all redness here. And let us see what we find in the duodenum also. So I'm going in the first part of duodenum to see if there is any duodenitis or duodenal ulcer as we found in the last patient. But here there are not much findings. Most of the things are looking normal. So now I will come back again, and similarly in the last patient, again we'll take here a biopsy for H. pylori again. Then we'll treat this patient. Now for esophageal, for patients who are having a very large hiatus hernia, as Hemant rightly told, lifestyle modification is very, very important. So if you have your dinner and you go to bed immediately within half an hour, then you will have lot of volume reflux, and then your symptoms will not resolve only with medicines. Secondly, weight reduction is also very important. Changing your habits, if at all you have any social habits like smoking or alcohol, that also has to be cut down. And most of the patients which I advise them that you should not have a very heavy non-vegetarian diet at the night. That is also very important, because this food will not get digested very early as compared to a vegetarian diet. See, redness here, lot of redness here. So I have already taken a biopsy. Now what we do for hiatus hernia, can you guide Hemant when we should do a esophageal manometry and when these
Yes.
patients will require surgery?
Yeah.
Okay. So
Yes.
as you keep on discussion, I will go to the next patient
Yes.
and keep my next patient ready. Okay. Chandan sir also can tell us about his experience about treating hiatus hernia patients.
Yes, sir.
Okay. So I am
Yes.
coming out. We have appreciated findings: severe pan gastritis and a very big hiatus hernia.
Yeah.
Yeah.
How you measure the length of hiatus hernia? Can you?
Now,
just-
yeah, I will tell
Okay.
you.
So you have
So this is the diaphragmatic pinch here.
yes.
This is the diaphragmatic pinch here, which is around 38 centimeters.
Yes.
38 centimeter is the diaphragmatic pinch here. And as I come out, this is the 35 centimeter. This is
G
the G junction.
Yes.
Okay. So almost 35 to 38, 3 centimeters
centimeters.
hiatus hernia here. Okay. Now this patient is not going to respond by medicines, that you keep in
Yes.
mind.
Yeah.
Unless it is a very elderly patient, then you don't want to do anything. But if the patient
Yes.
is very young, less than 60 years, then definitely he will require some surgical form of treatment.
Yes.
Okay. Yeah.
Yeah. So what is important is interpretation. Once you get the reports, you have to see that whether.
A very interesting patient. Now this patient has very severe abdominal colic, and then he was investigated outside. He also had a history of high colored urine and some yellowness of eyes. So he was investigated, sonography was done. We showed that there were multiple gallstones.
Yes.
Okay. And then further he was investigated. They found that the LFT was deranged. So a MRCP was done, and we showed that the bile duct is dilated and there are multiple stones in the bile duct. So now what we are going to do is a procedure which is called as ERCP. That means we are going to go inside the bile duct, and there were multiple stones in the bile duct. Inject contrast, please. So you can see here this structure, which is a very bulbous. It is called as ampulla of Vetter, which is present in the second part of the duodenum. So now through the opening of the ampulla of Vetter, we have entered inside the bile duct. Inject the contrast, please.
Correlate the image on this fluoroscopy
Yes,
also.
yes.
There is a scope. Once he'll inject the contrast, he will see the
Contrast
CBD
contrast.
and
See
the
on the
pancreatic duct. Ampulla water has got a common opening into the second part of duodenum of
Inject,
CBD and the pancreatic duct together.
So now we are taking what is called as a cholangiogram, and on cholangiogram we are going to see how many stones are there exactly and what is to be supposed to be done for this patient. We are going to inject, we are going to take a cholangiogram. Inject please, inject, inject. My assistant is injecting contrast inside the bile duct. Give the X-ray image bigger X-ray image please. Can you change the X-ray image to big size? No.
Yes,
No,
you can
not
see.
possible, not possible. So, okay, there is
This is
some
very difficult procedure. Cannulation is very much difficult
So
sometimes.
now I am going to do as again a separate procedure which
As
is called
Dr.
as
Bhandari,
a
that is why he is doing so easily. Otherwise,
what is
you
a
can
procedure which is called as sphincterotomy. So I am
Yeah.
going to go a sphincterotomy. That means I am going to cut it open, because unless you cut it open, you will not get the stones out. So now I am going to cut it open, but it has to be done very gently, because if you do it very fast, there will be a lot of bleeding because of the edema here. Slowly, 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 I am going to cut it open widely, and then we are going, we'll go inside with using a special instrument which is called as a basket, and then we are going to remove all these stones. Okay? So
Yes.
now we have done a wide sphincterotomy. Now I am going to use a separate instrument,
see
and
the
see lot of
see
pus
the
and
pus
and
coming out.
and sludge also is coming out here.
Yes,
See,
a lot of sludge and pus there.
slowly, slowly. So I am going to use a special instrument which is called as basket.
This causes cholangitis to the patient. This causes LFT derangement. This causes the high WBC count and sepsis.
So in
Gallstones, unless it is impacted, causing empyema. This is the important thing.
So in such patients, we should not do things at ease, but we have to do fast. We have to
Yes.
explain to the patient that this procedure has to be done fast. Otherwise, what they do, they try to seek help from alternative medicines. But once the patient has bile duct stones, then alternative medicine is also not going to work. That you keep in mind. For gallstones who are asymptomatic, alternative medicines can help. But here, it is a completely different situation. Patient has jaundice, patient has cholangitis, there is sepsis, there is infection, he is having severe pain. So he'll require some form of intervention. So it is better to do earlier. Otherwise, what happens? They can go into renal failure also sometimes. So I'm going to use a special instrument which is called as a basket. And with this basket, I will go inside the bile duct and then remove the residual stones from the bile duct. So this bile duct.
Lot of bad sludge there.
Yeah, see, lot of things are coming out.
Yeah, yeah.
Yeah, keep the
This
stent ready,
patient
please.
has some comorbidities like diabetes.
No, he's very young patient. Only 40 years, no complaints. Nowadays, we are seeing gallstones in very young patients
Yeah,
also.
yeah, I've seen 15
And
also. I
especially-
operated one
especially,
of the physician's daughter
and,
also.
and especially male patients also. In old days, we used to see gallstone patients in female patients
Females,
only.
Yes.
Fat fertile female of 50, 40. But here nowadays, we are seeing in young male patients also. So I'm going to flushing. This is an instrument which is called as basket.
Yeah,
And
we
with
can
this
see that.
basket, I am going to clear the bile duct. Close the basket again. Again, close the basket. Again, we go inside this wide opening. That is the reason we have to make this opening very wide. Otherwise, you will not get the complete the muck out.
Clearance. Yeah.
Open the basket, please. Keep a stent ready. Now, as you, what happens once this jaundice is settling, then patient is eventually subjected to cholecystectomy. If you can appreciate on X-rays, can you reverse the image, X-ray image? There are 3 stones in the gallbladder also. So now, for this patient, there is no chance that he will be able to conserve his gallbladder. He has to undergo a cholecystectomy procedure. Can you reverse the image, please? X-ray image reverse. उधर करना reverse. इधर डायरेक्ट हो रहा है क्या कर रहे हैं? एंडोस्कोपी का एक्सरे.
Flip करने को बोल रहा
हाँ,
है.
flip,
Endoscopy की
flip.
जगह X-ray. We can see the gallbladder there.
You can appreciate that.
Yeah, we can see.
Yes, you can
Yes.
appreciate. So now what we are going to do?
Big large
We are
size
going to
stones.
place a temporary stent here. So how this stent will help? It will prevent further migration of the stones from the gallbladder.
Yes.
That is very important. And once the patient undergoes a cholecystectomy by expert surgeons like Hemant Patil, Dr. Chandan sir, then eventually they will refer to us for removing of the stent. And when we remove the stent, again we do a complete cholangiogram and again we clean, because there can be lot of still migration of small stones in the bile duct. Okay, this is the process. Hemant, Chandan sir, want to add any comments?
Yeah, I just wanted to know what are the common comorbidities, that was diabetics and all this.
Yes, diabetic patients are prone for, no, not in this patient,
Yes.
but as you said, diabetic patients are more prone for gallstones as compared to normal
yeah.
population.
Exactly that point I
Yes,
want to stress.
yes,
Yes.
yes.
That the patient with diabetes
If
as
patient
a
has diabetes,
asymptomatic patient with gallbladders.
then you should not conserve. Eventually, is going to require surgery. And if they come in acute phase, the surgery is also very difficult. That will be a lot of adhesions, there will be a lot of pus everywhere. So if the patient is diabetic, then better he undergoes surgery earlier than rather than late.
Absolutely
So now
correct.
this black thing what you are seeing is a stent which is going inside slowly, slowly.
Yeah, we
I
can
am
see
pushing the stent inside. Now the complete clearance has been done. A sphincterotomy was done. All the muck in the bile duct was removed. And now a small stent is placed inside the bile duct. What will happen? This stent will reduce the jaundice. It will keep on, it will further prevent migration of the stones from the gallbladder also. And patient will become completely asymptomatic within next 1 week. The jaundice and infection will resolve. And then eventually within 7 to 10 days, he will go for cholecystectomy.
This
Okay?
is a self-retaining stent.
Yes,
It will not-
self-retaining stent will not either go inside or come outside because
Yes.
of this flap here.
Yeah.
So because of this flap, the stent will not go inside, and there are multiple flaps inside also that will prevent the lower migration of the stent. Huh?
Yes.
I hope our friends are appreciating. If they have any doubts, they can discuss with you.
Yeah.
In the meantime, I'll go to the next case.
Yes.
Wha-
Yes. We'll discuss that. Just about, let's see the next case. Yeah, sir, we are with you.
Now this patient, very elderly male patient, and he had dyspepsia since many years, and he never bothered what was going wrong with him, and he used to keep on taking medicines, and he used to feel better, and then after many years he has landed with us. So when we did his upper GI endoscopy, we found that he is having a very chronic duodenal ulcer inside, and that was almost causing gastric outlet obstruction. So we know that chronic duodenal ulcers can cause a benign type of obstruction here.
Yes,
So you can
picture.
see he has a lot of gastritis, you can appreciate.
Yeah.
Yeah, this form of gastritis, a severe pan-gastritis here. As we keep on going down, you can see more and more redness, red, almost very angry stomach, see?
Yeah, we can see red out.
Very angry stomach. And now as I go inside, you can see the pylorus, but there is no opening here.
Yeah.
Or there is a very minor opening here in between the stomach and the duodenum. So
Yeah.
what I am going to do, I have already done a upper GI rest of the findings were normal here.
Yes.
So for these patients, our protocol is to do dilatation, balloon dilatation, because he is not willing for immediate surgery. He wants to wait. Generally, there are two protocols here. You do
Yeah.
balloon dilatation once or twice, and if they is not responding, then eventually he will go for a gastrojejunostomy. So there are two options, one endoscopy and one surgical option. So now we are going to do a dilatation for him. Let us see how he behaves. And in spite of dilatation, if he is not responding, then eventually he may require a gastrojejunostomy also. Because what has happened, many years, it has become completely fibrotic. So he may not respond as a normal person. It is not a very simple duodenal ulcer, but a chronic duodenal ulcer, okay? So opening is also not seen here, but I'm going to try and see if I can see an opening here. Very difficult, can be sometimes very difficult. Oh. See, this is the opening. You can appreciate? Where? No, it's not one properly. No. Wait. Wait, VIP patient. Come here. And wait. So we have to be very careful here before we pass a wire.
You have to equally followed with fluoroscopy.
Yes,
the
yes.
X-ray image.
So now this, we are using a special balloon which is called as a CRE balloon. Now with this balloon, I am going to dilate this pathway. It is exactly, if you want to know, it is exactly at the D1, D2 junction.
Yes.
The pylorus is completely dilated. So I am going to use a balloon which is called as a controlled radial expansion balloon. And with this balloon, we are going to dilate this opening till 14 mm. So now my assistant will go and do a dilatation. So dilate, please.
You can
Yes.
see the balloon dilating.
So elderly patient, he doesn't want to immediately undergo a gastrojejunostomy. All the options were given to him. Either go upfront for a gastrojejunostomy or do a balloon dilatation. Now balloon dilatation generally we do for 2 or 3 times only. In spite of 3 times dilatation, if it is not opening, then it is a failure of endoscopic treatment, and then eventually he will go for surgery. That has to be done. Okay, but nowadays with good medicines which are available like proton pump inhibitors, we can avoid surgery in almost 50-60% of patients, not 100%, but yes, 50 to 60% of patients will respond nicely to only dilatation with using this balloon. Okay, so how long we keep this balloon? Maybe for 2 minutes we keep this balloon here, and then we'll try and negotiate the scope across the narrowing and see inside the duodenum what is going wrong. So how much is the diameter now? 12 or 13? Kitna hai? It is now inflated 12, so I am requesting him to go till 14 mm, and then we'll keep it till 2 minutes.
So what my boss used to say,
Yes.
if you are seeing a surgery and you are thinking that it is so simple, that means that surgeon is so good that it is making you to see it simple. So this way is Dr. Bhandari doing. This is not a simple procedure. This is so experienced. That is why it is looking like cakewalk for us.
But we have with Dr. Chandan here,
Yeah.
who has lot of experience with gastrojejunostomy, because in those years there were no medicines.
Yes.
There were no drugs like proton pump inhibitors.
Yeah.
What we had is only Rantac.
Yes.
So sir wants to add any points here,
Truncal
because he must have done lot of patients of gastrojejunostomy,
Yeah, truncal
chronic
vagotomy.
duodenal ulcers.
Thank you, thank you.
Yes, sir.
See, before the PPI came into the vogue,
Yes.
there was a big time, you know, I started somewhere in 73, my practice as a general
Yes,
surgeon.
yes.
And I don't think till 88 we had anything. And there was a big time when my mentor, and
Yes.
you all know him, Dr. H.S. Bhanushali
Yes.
from Thane. We used to do, in those days, truncal vagotomy with gastrojejunostomy. That means we used to cut the anterior and posterior vagus,
Vegas now, yes.
and we used to do posterior gastrojejunostomy.
Gastrojejunostomy, yes.
And I tell you, in those days we used to have very bad DU people. And we used to have, you know, a lot of emergencies of DU perforation.
Perforations, yes, right.
In
right.
nowadays, I don't see at all DU perf. And in those days, practically every week, 10 days, 15 days, there was the one DU perforation.
Yes.
So, those were the
So now
days.
proton pump inhibitors are called as chemical sclerotherapy. That means if you treat them with these medicines, almost the 100% of the ulcers will respond to them, and
Yes,
then
yes.
you will not have recurrence, and eventually you will not have a chronic duodenal ulcer. What happens if the ulcer is not healing? Then eventually it will turn into chronic duodenal
Fibrosis.
ulcers and fibrosis. Yes. So if the ulcer is acute and there is no fibrosis, then this type of narrowing will not happen.
Yeah. So it's very important how to treat. So when patient has got diagnosed with endoscopy and ulcer, either it is gastro ulcer or duodenal ulcer, you are given a PPI 4 to 6 weeks, whether that is adequate for that patient in spite of giving a HP kit. So it is mandatory to do a repeat checkscopy after 6 weeks to 3 months
Yes,
to
yes.
label that patient that this is cured. Otherwise, this patient will have a chronic ulcers, then a fibrosis. As sir said very rightly, initially this PPI was not there, medicine was not evolved, we are not knowing how the duodenal ulcer looks like. That time patient used to take painkillers like that for pain, and this patient used to come to emergency with a duodenal ulcer perforation. When my recidive was going on, it was minimum 1 to 2 perforation peritonitis per emergency,
में चल रही थी?
per unit. It was so bad that time. Nowadays we don't see it. But don't let your patients leave like
So
that.
now we can
that I have
appreciate
given
here, Hemant.
treatment. Checkscopy is must.
Can you appreciate here? We have gone across the ulcer now, and
Great,
we are in the
great.
second part of the
Well
duodenum,
done.
third part.
Yes.
And
Well
we
done.
have completely dilated that part. But what happens once you dilate, no, again eventually slowly it will get
Yeah,
narrowed. Yeah, that
fibrosis.
is the problem here. It will not stay as wide as it is seen right now. But anyhow, we have given him all the options. We have told him that we are
Yeah.
going to do this only for 3 times, and if it doesn't work, then we have no choice but to do a bypass procedure.
Yes.
Okay?
Yeah.
So now you can keep on discussing. I
Yeah.
will shift to the other room.
So we were about why gallstones occurs in females initially.
You are ready now? So we have a very young male here. He is almost 20 years old, and he kept on having bleeding PR.
Yes.
And 2-3 important things when you have a patient with bleeding PR. First, you have to ask the patient it is painful or painless. That is very important. And second, most important thing is to ask them if it is having, it is mixed with stools or it is totally separate. This is very important. And third is, does he have constipation or he has diarrhea?
Yes.
So this patient, he had a diarrhea, means he was passing stools 4 to 6 times per day. Secondly, even though it was painless bleeding, the bleeding was mixed with the stools. That is very important history here. So that will differentiate between a hemorrhoidal bleed and anything which is going inside wrong. So as you can see here, this is a colonoscopy test. We have gone inside here and there are multiple ulcers in the colon. Now this is a very classical case, what is called as ulcerative colitis. Now these patients will have diarrhea, they will have stools 4, 6, 7, 8 times, there will be no constipation. As we know, hemorrhoidal patients, they can have constipation. They can have bleeding which is fresh bleeding, but it is totally painless. And the bleeding is not mixed with the stools, that is very important. So if from history only you will get a fair idea what is going wrong with the patient. So this is very important for our general practitioners to how to differentiate. If the history is otherwise as compared to hemorrhoids, then you should always see that patient is not having anything else above in the colon. I have seen a lot of these patients undergoing surgery for hemorrhoidectomy and eventually they get referred to us for colonoscopy. So Hemant, you want to add here something?
Yeah. Sir is there, sir will serve.
Exactly, you know, good number of patients, they come to general surgeons when the history is not taken properly.
Yeah.
Yes.
And there the problem starts. खून आता है, piles है, operate करो. But please remember what is the frequency of stool, what is the color, consistency, since long, and you please, if you can't do, please ask any surgeon to do first PR proctoscopy. PR proctoscopy is an essential part of the clinical examination. And if a surgeon decides that this is piles, but nowadays we are very cautious. Sometimes we miss that we just think it is piles, but there is something higher up.
Yes.
And
yes.
that whatever is higher up has to be cleared by GI endoscopist.
So in olden days, sigmoidoscopy was must for any patient of bleeding PR.
Yeah.
A routine sigmoidoscopy was must.
Yes.
And nowadays we do a routine colonoscopy. So if you can appreciate here, carpet of ulcers in the colon.
Yeah, we can see
Carpet
very
of
well.
ulcers.
Yes.
Carpet of ulcers. And this is very classical of ulcerative colitis.
Colitis, yeah.
Okay. So we are coming out slowly. We took a biopsy to see the grade of ulcerative colitis. Multiple ulcers here, multiple ulcers. And then now we have made a diagnosis. There are no hemorrhoids here to appreciate. You can see here, no much hemorrhoids.
Yeah.
And now we have made a good diagnosis of ulcerative colitis and now we can treat him easily.
Yes.
So now we can continue our discussion.
Yeah.
In the meantime, I'll go to the next case.
Sir, here also in PR,
Can
yeah,
you
we
hear
are
us?
ready.
Now
Yes.
this elderly male patient,
Yeah.
and he was referred to us with stool local blood positive. So a routine colonoscopy was done for him, and then we found that there was a polyp in the rectum.
Yeah.
This is the rectum here. I just inserted the scope, and it is round. This is the anal verge.
Yeah.
I inserted the scope almost 8 to 10 centimeters here, and these are the early polyps in the rectum. And as we all know, all colonic polyps are pre-malignant, and most of the gastric polyps are hyperplastic. So whenever there is a polyp in the stomach, generally we don't excise them because they sometimes can be PPI induced also because of the PPI abuse. But this patient, these polyps are pre-malignant, and that is the reason all colonic polyps should be resected. So now what we are going to do to plan the resection for this patient. Now this is a injector here. I am going to inject something below this polyp. Give me a needle, please. So we create a saline cushion below the polyp so that there are no chances of perforation. Inject, please. Keep a snare ready. Inject. So as you can see here, it is getting elevated. So this is a saline cushion below the polyp. What happens if you directly do a polypectomy, then patient there are chances of bleeding and very remote chances of perforation. So we don't want to take any chances. So we are creating a saline cushion below this polyp. Inject some more. Done. And now we have a special instrument which is called as a snare. I'm going to show this instrument inside. Now can you show this from outside? You may not appreciate, but from inside I'm going to show you how the snare is there. This is a instrument which can resect this polyp. So I'm going to remove this snare within the lumen of the colon now. Now open the snare. Yeah, open it completely. Now this is a snare instrument. So I am going to catch this polyp first inside this snare very slowly. Very slowly, I'll ask my assistant to hold this polyp here. Now please close it slowly. Close it more. And once it is completely closed, don't crush it, just close it. I am going to resect it with current. Okay, so now give me a cautery. Cautery is there in position. Cautery is working? नहीं चल रहा है. सब चेक करो ना रे पेशेंट ने पहले से. Saturation कितनी है? There is some issue with cautery, so I am just waiting. And using a combination of cutting and coagulation current, I am going to resect. Otherwise, there can be a lot of bleeding. So slowly, I am resecting it with current. Slowly, you can appreciate there is some charring here. Now close the snare tightly, completely. Close it completely. And now it is very important to have histopathology here. So we have to remove this polyp. Sometimes it can get lost in the colonic lumen. So I am going to resect, withdraw it completely inside the channel. And then this polyp has to be sent for histopathological examination. And we have to see if it is a benign polyp like a tubulovillous adenoma or it is a early cancer, colonic cancer. Suction is not working. Suction. So we can see here, give me biopsy bulb. We have removed this polyp here, you can appreciate here. Signal hai tikde. Hemant?
Yeah, we can see the raw area.
Yeah,
also.
see,
There's no
and you
bleeding
can see
also.
the raw area, there is no bleeding. So this saline cushion will help us to prevent bleeding.
Yes.
It can also prevent a perforation here. But since it was a very small polyp, the chances of perforation are very remote. Blood bleeding is a very important problem. And third means sometimes there can be delayed hemorrhage also.
Yeah.
So we have resected it completely from the base. This is the cautery artifact. And now we are going to send this polyp for histological examination. Mostly it will be a benign, but sometimes you can get malignancy at the base of the polyp. So that is very important. But we did a wide excision endoscopy for him, and we found that there were large varices.
Okay.
So today with me I have Dr. Nutan Desai. Can you see her?
No.
Dr. Nutan Desai is a very senior gastroenterologist at Fortis Hospital, and we have asked for her help. What we are going to do is to show you what is the role of fibroscan here.
Yes.
Okay, so next to madam, please.
Yeah, good afternoon, ma'am.
Good afternoon. So basically, fibroscan is a non-invasive method to assess the degree of liver fibrosis, and its use is basically in monitoring patients with all kinds of liver issues, alcoholics, non-alcoholic, obese, metabolic liver disease patients, AIH patients, and those who have suspected drug-induced liver injury, etc. So here the main role is in the pre-cirrhotic stage, where you are looking at the degree of fibrosis, which otherwise would be known only on the basis of liver biopsy, and liver biopsy being an invasive test with its inherent small risk, we tend to avoid it. Also, liver biopsy has a very small tissue which is sampled, and therefore there can be sampling error sometimes in diseases which are patchy and diffuse. So therefore, fibroscan is a good, reliable method to look for degree of fibrosis. Now there are some limitations in the sense that it is a highly operator dependent procedure. Secondly, there are two types of fibroscans. One is ultrasound based, another is non-ultrasound based. Both of them have equal sensitivity and specificity. In certain situations, the non-ultrasound based fibroscan has some limitations, like you can't do it in patients with ascites or those with morbid obesity. All types of fibroscans will give elevated values in patients who have necroinflammation in the liver, like in acute hepatitis or an ACLF patients, or in patients who have cholestasis, or those who have a heavy fatty infiltration in the liver. So therefore, these are the limitations you have to keep in mind. But whenever you are looking at a patient who has a history of alcohol use and you are not sure whether he has a significant liver damage or not, you can do a fibroscan. And if it is a grade 2 or above fibrosis, a fibroscan will easily pick it up. Similarly, in patients with autoimmune markers positive, with deranged LFTs, you can do this test to look for evidence of liver disease and then monitoring of the liver disease in case it is pre-cirrhotic. In cirrhotic patients, the use is mainly to prognosticate these patients. So you can use the fibroscan values to differentiate between patients who are likely to develop decompensation or who are likely to have a rebleed based on fibroscan values.
So, madam, suppose I have a patient of maybe NASH. So, when we should do a patient, immediately, or what
So
are the...
there are some non-invasive markers too. So, like you can calculate the FIF4 or you can calculate the APRI or you can calculate the GCR ratios. Now, if these ratios are suggestive of fibrosis, then you should send the patient for a fibroscan. Doing indiscriminate fibroscan is not going to help much, but in appropriate cases chosen well, this is a very good investigation.
Hemant, anybody wants to know more from madam?
Welcome, madam. Dr. Nuthan Desai, Dr. Chandan here.
Ha, sir.
Nice to see you here.
Thank you, sir.
Madam is the senior most gastroenterologist at Fortis Hospital with vast experience. And she has given you a lot of information about the non-invasive method of assessing the fatty liver. If you have any query, please ask her.
Sir, I have one small query. Lot of patients will ask in OPD कि मेरा liver कितना खराब हो गया. So will fibroscan, suppose a patient who is having a advanced cirrhosis, we do a fibroscan, we find that there is lot of fibrosis, maybe 40, 50, 70%. Does it have venue? Can we actually tell the patient कि आपका 50%, 60%, 70% liver weak हो गया है?
So basically, now there are quite a bit of technological improvements in the fibroscan machines also. So now there is a fibroscan machine with a cap attenuation value given. If you are using that machine, then yes. Otherwise, the plain fibroscans which are currently available do not tell you about the degree of fatty infiltration. And fat will overestimate the degree of fibrosis. So there is a little bit of a limitation there. But you can have other non-invasive tools to calculate the degree of fibrosis. And if your fibrosis is F3 or above, then definitely it tells you that you are in a danger territory. And if you don't act fast, then you are going to progress to cirrhosis or have complications of cirrhosis.
Right.
Thank you, madam. I want to
Thanks,
thank madam
thanks.
personally
Thanks
because
a
I
lot.
requested her, and then from her busy schedule, she has come here to help us out. Thank you, madam.
Thank you so
much.
much. Thank you, ma'am.
We'll talk about fibroscan again.
He's ready with the next case.
Yeah.
Very fast.
So now I have taken this patient who is chronic alcoholic, and he has anemia, low platelet count, PTINR was deranged, but everything was managed conservatively now. He's doing well, and now we want to see what are the grade of varices, and can we do banding for him, because he had one episode of hematemesis. So I'm passing the scope across the GE junction, and I'm going to show you what we can see, what are the changes which we see in the stomach in the cirrhotic patients. And here you can see classical, which is called as portal hypertensive gastropathy. So this is very classical of portal hypertensive gastropathy. It is called as snake skin appearance. This happens because there is a lot of pressure for the blood to flow across the liver. So the entire blood is now diverted to the stomach and the esophagus. And that is the reason this diverted blood causes varices. And here you can see very severe portal hypertensive gastropathy. This also can sometimes bleed and cause anemia to the patient. And as I'm coming across, I'm coming out, there are multiple dilated veins here in the lower esophagus. Here you can see, appreciate these veins here.
Yes.
These are the varices, and this patient already had hematemesis. That is the reason we are going to do a banding procedure for him. Okay?
Yeah.
So a banding procedure is done for patients who are having hematemesis, for cirrhotic in patients of chronic liver disease, or any etiology. Maybe it is related to hepatitis B, it is related to hepatitis C, or alcoholic patients. Maximum patients which we get are alcoholic patients, and second which we get are hepatitis B or hepatitis C. But nowadays we are getting patients who are also having metabolic syndrome. Standard is doing esophageal banding, variceal banding. Now glue injection is done only when there is active bleeding.
Active bleeding.
If the bleeding or not, if the varices are not bleeding actively, then we don't do glue injection, then the only treatment is banding. So now the banding has the lowest possible complication rate. It is very easy to be done. It can be done by people who are having less experience also. And it has very good results, that you keep in mind. Just because it is easy we are not doing, but the fibrosis rate is also very high. Only problem is it has to be done more frequently.
Yes.
That is the problem with banding, but then it is safe also, that also you keep in mind. It is a very safe process. It can be done on OPD basis also. You don't require admission. The only prerequisite for banding is that you have to see the liver function test, you have to see the PTNR, you have to see the platelet. Everything is optimal, especially the platelet count. We have no cirrhotic patients have very low platelet count. Now hold the scope please. I am going to suck this varix in the barrel, and this is how we apply a band here. Now you can see I have ligated this first varix.
Yeah, we can see.
Now, so generally we start from the gastroesophageal junction and we then progress upwards. So this is the second varix I am going to ligate. So this is the second varix, and this how we this band has this barrel has 6 bands. So up to 6 times we can fire this band. So only after you can appreciate here, after applying only 2 bands, we start from the G junction. What happens if you apply a band at a varix which is at the G junction, the entire column will collapse.
Yes.
So what happened here, once we applied only 2 bands, the entire column has not collapsed, and we are not seeing any varices in the proximal esophagus.
Yes.
So generally we don't create any artificial varices. That means just because there is no varix here, I cannot do suction and apply a band, because it will tear the esophageal mucosa. And the only complication of this banding is that there can be ulcers here. That is the reason if the liver function is very poor, then we should always wait to optimize the liver function first. And once the liver function is optimized, that means if the PTNR is deranged, then we give them fresh frozen plasma. If the platelets are very low and patient has history of hematemesis, then we have to give him a platelet also, a concentrated platelet infusion. So once this is done, we subject this patient for banding, and then we observe them post-procedure also very closely, because sometimes they can have delayed hemorrhage. This is the only complication, otherwise there is no complication. And we ask them to take liquid diet for 2 days, and then eventually they can take a normal diet. So as you can see here, after banding, only applying 2 bands, the entire varix has collapsed. And there are no varices here proximally to do any further treatment, okay?
Fantastically done.
Yeah, yeah. So now we shift to other cases. I think we are only 1 or 2 cases, and then we call it for the day, okay?
Great, great.
2 more cases. Your discussion.
Yeah.
It is very important for patients with fatty liver to do lifestyle modification, which our
Yes.
patients are very reluctant.
Yeah.
The moment you tell them to do weight reduction, and then वो बोलेंगे कि हमको कुछ दवा दो वजन कम करने के लिए. So that is what is the current situation in our country. So now in this patient, we are coming to this this patient who is having bleeding PR, and that was continued almost for 3 to 6 months. Then surgeon did a per rectal examination, and they found that there were no hemorrhoids significant to cause a lower GI bleeding. And he also had some anemia, and alternating bowel habits. That is very important. You should keep in mind that any patient who is having alternating bowel habits, that means sometimes constipation and sometimes diarrhea. Now this is a very, very, very important complaint of this patient, which you should never neglect. And then he was eventually referred to us for doing a colonoscopy. And once, as you saw, I started the colonoscopy at the rectum, and then we came at the sigmoid colon here, and this is a big ulcerated lesion here. You can appreciate this big
very
ulcerated
well. The
lesion,
big
which is
growth
causing almost near total luminal narrowing. See, some amount of fluid which is coming here, but the scope will not go across this growth. Now what information surgeons want here is what is the length of the lesion from the anal verge. Now this lesion is almost 20 to 25 centimeters above the anal verge, because if it is high up in the anal, in the colon, then they can do what is called as anterior resection. But if the growth is in the rectum only, then the treatment suddenly changes from chemo and radio. I think Hemant Padil is here who can guide us. But now what is the next step is to take a biopsy in this patient, then do a staging procedure, which can be in the form of CT scan. And once the staging procedure is done, a biopsy is done, then I think we refer this patient to our surgical colleagues, Hemant Patil here and Chandan sir, and they take it further. So sir, Hemant, can you guide them further how we need to treat them further?
Yes. So this is a case of suspected colon cancer. This is in the sigmoid colon. That is, I told you red flag sign for colonoscopy. The similar thing is there. Once you get a colonoscopy done or a biopsy done, then biopsy, if at all it comes positive, like adenocarcinoma of colon, then important thing is that whether now you have seen a intraluminally. Now we'll have to see the extraluminally how this cancer has spread. So what is important is our friend is there, will do a CT scan, abdomen and pelvis, which will tell us whether there is pericolic, there are stations of node, whether pericolic nodes are involvement, whether retroperitoneal nodes are involvement, whether aortic nodes are involvement, whether this patient got ascites, whether his patient got liver mets. If there is nothing, only local liver, and there is no serosal deposits anywhere in the abdomen, then we can subject this patient. If at all length is adequate, is away from the anal verge, we can go for straight away from anterior resection and remove that. And if at all this patient has got ascites, omental mates, peritoneal seedlings, then we'll have to do a PET scan whether this has got patient about distant mates, not about abdominal mates, distant mates. If there are no distal mates, then we can straight away go for a neoadjuvant chemo and radiotherapy. Downstage the disease, control the disease, then do a primary surgery. And if at all this growth is lower down, we do nowadays ultra low resections, which can save the sphincter. Otherwise, previously it was like a permanent colostomy for the patient. Nowadays, we'll try to avoid by neoadjuvant chemo radio given. Even if we get a 3 centimeter margin below the tumor, we'll just do the anastomosis. But mild well for such patients, if you are doing a low ultra anastomosis, we'll have to have diverting temporary colostomy outside to safeguard this anastomosis for 4 to 6 weeks. Once this is saved, then we'll close down this and then patient will be fine.
So as far as colonic malignancies are considered, just keep in mind that colonic malignancies are a good type of cancers. Why? Because they respond to chemotherapy very nicely, and a surgical treatment also, they do well with surgical treatment. Unlike hepatobiliary malignancies, which are very aggressive in type, colonic malignancies generally respond very nicely to whatever treatment is offered, unless they are advanced in disease. So if the disease is very localized to the colon and it is operated early, then these patients do very well with surgical treatment in long-term basis, even on long-term basis. So it is generally called that it is a good cancer to have. If at all you want to have a cancer, then colonic malignancies which are localized to the wall. But very important to keep in mind that you should never neglect the symptoms. Just because patient is having constipation, you cannot keep on giving him laxatives. This patient is having alternating bowel habits. That history is very, very important. You cannot neglect, and the moment you hear this, he should go for some type of imaging, either in the form of CT scan, a stool test, CBC, and if required, colonoscopy. These are 2-3 things which you have to do. And if you do a stool test, eventually you will find that the stool occult blood is triple plus positive.
Yes.
This is very important. And if the patient has a stool occult blood positive, which is very significant, then he should be subjected to colonoscopy, no doubt. Patient had significant dysphagia to solids, and then she also has lost weight. So now she was investigated with us, and then we found that there is a luminal, completely luminal narrowing here in the esophagus, lower esophagus. The scope is not going across, and here immediately you can see what is a growth here. Oh. Like we saw a growth in the colon, we can also see luminal narrowing in the esophagus. So now for this patient, we have not yet decided what is to be done because she was completely dehydrated. She was not able to take anything orally. So what we did, we just passed a Ryle's tube. We are trying to build her up. And once we build her up, maybe the biopsy is squamous cell carcinoma. And maybe once we build her up, either we do just a palliative stenting because she is very old, she is very fragile. Or maybe we can give her some radiotherapy. That is not yet decided. But I just wanted to show you how a malignancy in the esophagus looks like. So you can see here ulcerated lesion, proliferative region, which is almost causing near total luminal narrowing. Can you appreciate this, Hemant?
Yeah, we can see.
So patients who are very old, very fragile, the only treatment which can be offered to them is a form of stenting. So we do metallic stenting, like we do stenting for our heart disease patients. Metallic stents, such type of imported stents are also available for esophagus. So we can place such type of stents, and the palliation part is taken care. Patient can take liquids and semi-solid diet. It is a very simple endoscopic procedure, and there is no much morbidity of the procedure as such, because once you give them radiotherapy, most of these patients don't tolerate, but she is very old and fragile. Her weight is hardly 32 kgs. Okay? नहीं कुछ नहीं करने का.
So this is very important that every patient doesn't need a surgery. Every patient is not fit for surgery. So something we have to do for the patient is what important is that anybody, if at all he is taking orally something, they are happy. If you do a feeding gastrostomy, jejstomy, even a peg, they will not get that satiety in the brain that they are getting something from oral. So this is very important. Esophageal stenting is for palliative care. Patients who are not tolerating chemo, radio, they are not fit for surgery. So this is a self-expandable metallic stent.
Help from your side so that we can help you better. If there is some renal problem, then I'll focus more on the kidneys. If there is some, okay, so that way.
So coming to our last case, Hemant now.
Yes, sir.
This is a colonoscopy. This patient had again stool occult blood positive, anemia, and then he was investigated, referred to us for a lower GI endoscopy. And I'll show you what important finding which we have found here. After many years, we did. He was diagnosed to have multiple ulcers in the small bowel, and biopsy was taken, and which has eventually proved to be a Crohn's disease. So this is what happens if patients are not investigated fully. If you do a CT scan, most of the time CT scan is normal. CT scan is absolutely normal, and here you can appreciate multiple small ulcers here. I'll show you. You can see these ulcers here, punctuate ulcers.
Yes.
See these ulcers, small carpet of ulcerations. Now this is the last case for today. So small here
the
ulcers.
growth is different, the ulcers are different.
See, you can appreciate these small ulcers.
Diagnosis on biopsy.
And once you take biopsies from these ulcers, you will get a real picture what is the diagnosis. Most of the times they are Crohn's disease. So I'll take biopsies from these ulcers now. So I once again want to thank Bhandup Medicos for giving us this opportunity, the president and the secretary of Bhandup Medicos. Also I want to thank the Arya Samaj people who have who were grateful to help us in giving the hall, and also they arranged for a delicious food. Then I also want to thank my entire staff from Mulund and Thane for helping us in managing these patients. I also want to thank Mr. Shinde and his team for excellent audio-visual help with this meeting. So without this, it was not possible. I also want to thank the moderators, especially you and Dr. Chandan sir, who came all the way from your precious timing and spent some few hours with us. And I think tea is ready there, Hemant? Yeah. I request everybody to have tea and just then you can make a move.
Yeah, great show, great
if anybody
number of
wants
cases,
to, if anybody
lot of
also
clinical discussion.
Have some comments, they can tell us.
Yeah, thank you, Dr. Bhandari. Excellent presentation, a live workshop. Few days back, I have discussed with one or two seniors also. We are also doing a live workshop for Bhandup Medicos for surgically.
Yes.
We are planning that. Thank you very much.
Thank you.
Dr. Parmar wants to say something.
Yeah, so let me just continue with that small request.
Yes.
That we need history. The other thing which I wanted to bring to your notice or awareness, I would like to ask Dr. Hemant Patil, when would you like to send patient for a shear wave elastography in liver conditions?
See, I am a surgeon. I know what is my domain.
Right.
If at all this is not a surgical case, I'll not waste my time and patient's time and their money for that. If at all I feel that grade 2 fatty liver function is dysfunction, lipid profile is altered, I'll send it straight away to a good physician or a gastroenterologist. They will manage, rather hepatologist. They will manage, they will know how to do a fibroscan, what is next, elastography and all. So it is very important that you should know your domain. As I said, patient is always right. If the patient is coming to your clinic every day and night, every fortnight with the same complaints, in spite of changing the medicines, think over that patient's complaint, evaluate that patient. If you are not able to evaluate, better to send to someone who is either a good gastroenterologist, physician or your surgeon colleague to evaluate that patient, but don't neglect such patients.
Exactly. Now, these days a lot of shear wave elastography is done, in fact for grade 0, grade 1 and grade 2. because on shear wave elastography, we can pick up grade 1 and 2. And if the patient is having grade 1 and 2, we can warn the patient that like you have grade 1, you have grade 2, and then we can quantify it on kilopascals
Yeah.
so that when patient comes 6 months later,
Yes.
depending on that kilopascal value, the
Yeah.
patient can be advised accordingly.
Yes, so this is very important when the patients are obese, hereditary problem is there, whether the family history of non-alcoholic liver disease is there, then this patient is directly going to that. So it's very important that even if it is non-alcoholic, but obesity, familial history of liver cirrhosis, non-alcoholic, then you can straight away go for that. The indications are very specific. Yeah. Yes, non-alcoholic fatty liver is very important. NASH is very much coming up into the market. It's all because of the lifestyle modification, food which is fat content too much. Yeah.